everybody, and welcome to this week's edition of Getting to Know Your Theorist. Last week we had a fantastic interview with Dr. Patricia Benner, and this week I have a real treat for you. I'm sitting here live with Dr. Catherine Kolcaba, the author of The Comfort Theory. Good evening, Catherine.
Hi, how are you? Thanks for having me here.
Well, thank you so much for your time. We really appreciate it and are excited to learn more. So can you tell me a little bit about your origins and the background of the comfort theory?
Sure, I'd love to. It actually started out in some of my very beginning nursing practices when I was on a dementia unit, and those patients need very special care. Many are nonverbal or at least have trouble verbalizing their needs, and the important thing is to try to keep them as comfortable as possible, especially when it comes to the end stage of the disease. Well, the problem is you can't always tell if they are comfortable in pain, spiritually upset, or whatnot. So I originally started doing some research around 1988, and the whole purpose was to delve into different ways of providing comfort, different levels of comfort, different areas of comfort. And so I did a lot of research, and I published and presented it at a conference with a lot of other wonderful speakers and writers, and they gave me a lot of feedback. Not only did they feel that it was good for the dementia patients, but in nursing as a general rule. So during my doctorate thesis, I did publish the first part of the comfort theory in about 1991. And since then, it has actually come a long way. I've made many separate articles with myself and other researchers that were interested in exploring the possibilities of using the comfort theory, and even have written a book.
Well, that is fascinating. Isn't that fascinating? And I'm sure our viewers and I am just dying to know, what's the comfort theory all about? Can you tell me?
I certainly can, but you know what may be better and maybe a little more fun than just sitting here talking is I have some diagrams that may make it just pop off and come more forward to be able to better understand it.
Well, sure. Let's go. Okay, boys and girls, here we are at the theoretical conceptual framework board. I've got Catherine here with me, and she's going to explain her comfort theory.
Well, thank you so much, Kelly. So first we'll just start down here at the end with healthcare needs of patient and family. The first major concept is, again, healthcare needs of the patient and family. Healthcare is a very stressful environment. There's lots of anxiety, many times pain, and those are probably the biggest common needs. The second major concept is the comfort interventions, and these are things that, for instance, the nurse can help to control. That may be pain management, it may be repositioning the patient in bed after surgery, it may be environmental factors such as keeping the door closed so that all of the outside activity going up and down the hallway is quiet, turning the lights down, those type of things.
Now explain to me this intervening variables. That one just doesn't make sense to me.
Well, that is those things that the nurse cannot herself control. It may be the patient's age, the patient's comorbidities, maybe previous bad experiences they've had in the hospital. We can't control those, but they may lead to some type of discomfort. For instance, maybe their last hospitalization, they were there alone, they didn't have their family, so they're thinking that's going to be the same way again. However, this time we can even ask them, is there someone you'd like us to call, would you like to talk to the chaplain, that type of thing. Okay. We couldn't control previously, but we can maybe help this time.
Okay, gotcha.
And with these things, we're building up to enhanced comfort. Again, that leads to, entails many things. Again, pain, their environment, any cultural aspects that may come into play, language barriers, things that we have worked on because now, as you know, many institutions have, they have interpreters on call, they have large print for people that can't see well, they have hearing devices for people that are hard of hearing. These all lead into the enhanced comfort. It's not always just about pain.
Okay.
Then with enhanced comfort, we come to health-seeking behaviors. Now what we have built up to at this point is that as we brought the patient along, they're more comfortable. Hopefully they're happier about their overall stay, there's less anxiety, less stress. That's what we're going for. So health-seeking behaviors then leads to some internal behaviors that the patient is now willing and has learned on their own that this is going to help their comfort situation. So internal behaviors would be things that keep, say, their homeostasis and in check, and then things at the cellular level. So if they're comfortable then and not in pain, then their blood pressure, say, would be better. That's these internal behaviors. Then we come to peaceful death is off. We don't always like to talk about it, but it's a very important part of the comfort theory, because when patients are at end of life, many things are going on. Not only is it stressful for the family, it's stressful for the patient, but a lot of times the patient is more comfortable than the family. So sometimes we actually spend a little more time talking with the family and seeing their needs, obviously addressing the patient's needs. But we want them to have a peaceful, dignified death. That's all very important to the comfort theory. Then we come over to external behaviors. Now, external behaviors are things that the patient may not always want to do, or maybe they're afraid to do. For instance, if you've had open heart surgery, your chest is very uncomfortable. Now, we can give pain meds, we can provide for a quiet environment, but what we really want them to do is to be comfortable enough to get up and do their physical activities with the physical therapist, and we've all experienced those patients that don't want to do that. However, if we've got them comfortable in all aspects of the theory, they are more apt to go into these external behaviors in a much better attitude, a much better comfort level. And again, these are all part of the health-seeking behaviors to get those patients to the point where this is more natural and they actually want to do it to get better because they've been feeling better all along.
Okay, makes sense.
So then the health-seeking behaviors leads to institutional integrity. Now, by that we mean the patient, again, has had a more pleasant experience, a quicker recovery. Means decreased length of time in the hospital, decreased, how should we say, those, things that we don't want to happen.
Poor measures.
There you go.
Measures.
There you go.
Mm-hmm.
And then with the institutional integrity, that leads us to best practices and best policies, and then one goes hand in hand. You can see where the arrows go back.
Okay, and I've noticed throughout here there are a couple of two-way arrows. We've got them over here in between health-seeking behaviors and needs bubbles. Can you explain the two-way arrows?
Yes, as a matter of fact, again, the thing is, once we lead up to enhanced comfort, which brings us to health-seeking behaviors, the more comfort they are, the more they're going to go for the health-seeking behaviors, and again, the more comfortable they will be, because the more, say, physical therapy we're doing, the more comfortable they're going to be working out those sore muscles or that surgery site. Again, better health-seeking behaviors. The more we get in and the more we do, I keep going back to the physical therapy, the quicker we're going to get out of the hospital, decrease length of stay, they're back home where they want to be.
Okay, so let me try to guess on this one. Best practices and policies. So let me think. An institutional integrity, institution with integrity will implement best policies and practices, but then because they've implemented those policies and practices, it makes them an even better institution. Is that right?
Pretty much. I think you've got it.
Okay.
Because then the word gets out. What a great place this is to be if you have to have surgery, or if you wind up there by an accident, a bad car accident or something, they're going to say, take me to XYZ institution. That's where I heard they do the best.
Okay. Very interesting. This framework has really helped kind of put things into the big picture and help us understand the comfort theory a little better. So let's go on. She's got another diagram to explain with us. Okay, so here we are at the taxonomy structure of the comfort theory. Catherine is here with me again, and she's going to explain all of this that you see going on here. So go ahead.
It looks a little busy right now, but as I break it down, I think it will just put the whole comfort theory together. So on this side, we have the context in which the comfort occurs, and those are four: physical, psycho-spiritual, environmental, and socioculture. Now across the top, we have the types of comfort, which is relief, ease, and transcendence. The basic premise of this is to give the patient relief in their physical, psycho-spiritual, environment, and sociocultural areas. Then the ease that comes from the ease of the pain or these other areas, and then transcendence, which is accepting these areas, which leads to the health-seeking behaviors we talked about before. So let's just start at the top. This is actually from a research article that I did in 2004, and our patient today is a 45-year-old Hispanic woman that's had colon cancer, and she's gone in to have her sigmoid colon resection, and she's immediately now into the PACU. So these are some things that are going on with our patient. So under the physical component, she's going to be in pain and most likely have some nausea. So we want to provide her with some relief, which usually comes with medications. And then to ease into more comfort, we're going to make sure she's comfortable in her bed. That may mean propping her up, readjusting her position, and then the homeostasis again, where say, for the ability to understand where this comes from, we'll just go with the blood pressure again. As the blood pressure comes down again with medications, then her pain level is going to come down, and then the homeostasis, all those blood and other lab values are going to come down too once we control that. But then we get over to the transcendence, which is, you know, the patient was wondering, how am I going to tolerate this pain when I wake up? And as we go from the relief into the ease into the transcendence, she's going to be like, I can tolerate this, I can do this, this is for my, my recovery, again, which leads to those health-seeking behaviors.
So you're saying that transcendence is a sort of like rising above and overcoming?
Yes, that was an excellent example. You said that better than I did.
Well, thank you.
Then we have the psycho-spiritual context, again, which we want relief from, say, anxiety. Obviously, she's anxious. You know, she is uncertain, again, easing to the easing process, uncertain about her prognosis. At this point in her disease process and her surgery, she doesn't know what the prognosis is. She's just coming out of the anesthesia, and she's going to need to, in order to accept it, to rise above these uncertainties, the need for spiritual support. Now, what we can do as nurses in a hospital setting is two things. We can have a chaplain come to talk to her. We can have her family there. Again, she is Hispanic, so we would need to take that into account. So we would need someone that would be able to help translate perhaps words that she didn't understand, that type of thing, because we want to, again, transcend to rise above this anxiety that she perhaps could have.
Okay.
Environmental. This is I think this is really important, and a lot of times it may get overlooked because as nurses we're very busy, we're in and out of rooms, we have more than one patient. But the PACU a lot of times is noisy, it's a bustling, it's a very, very busy place. There's bright lights and it's often cold. People coming out from their surgeries, obviously their body temperature has been lowered for the surgery. So as we're trying to get past this and find some relief, she's also feeling perhaps a lack of privacy because it's not like in a single room. There may be a couple of curtains, or there may be several patients with different nurses kind of very much close together. So what we need for her in order to transcend, we need to have calm and a familiar environment and the elements. So perhaps what we would do is we would put some warm blankets on her. Again, try to be as quiet as we can. If there are curtains, if it's a PACU where there are curtains we would pull those curtains around her.
Good idea.
Then that brings us to sociocultural. Now for her, again, an Hispanic woman. Now, in this particular study, this woman had very good English, but we also have to think that perhaps that not all patients speak as well English as you and I.
Or their family members.
Or their family members, absolutely. So, but the biggest thing is the absence of traditions and cultural sensitive care. A lot of Spanish cultures, the whole family is very, very involved. A lot of times it's at home where, you know, patients' families are coming and going, and they're not going to have that in the PACU, obviously. So there's, you know, the patient's family's not going to be present, and there may be language barriers. So again, we need to be very, very aware if they need a translator, if it's at the point in the recovery that they could have a family member, if nothing else, just come and sit quietly in the room. So again, the need for family support and maybe more information about what's going on and what's to be expected.
Okay.
So we have used the comfort theory through all of this. And a lot of times these overlap. It's just not 1, 2, 3, but they do overlap, and a lot of these things nurses do without even thinking. But again, it's very important that we make sure we chart all of these things so that we can chart and show how the comfort theory really does help and that it's accountable in nursing.
Okay. So I'm taking from all of these contexts that discomfort can occur in. It looks to me that it's more of a holistic approach. Is that right?
Absolutely.
Okay.
It's not just pain. It is about the whole patient.
Great. Okay. Holistic. Got it. Okay. Let's go to the PACU, everybody, and let's check out this patient in this scenario. Come on.
This is Mrs. Martinez. She's the patient I just received while on the PACU. Mrs. Martinez, my name's Suzanne. I'm going to be your nurse today.
Dolor, don't stop, family,
I don't know Spanish, so the only way I can communicate with her through language is by getting a translator phone. Lucky for me, I have it right here. Hello, I need to talk to somebody that speaks Spanish for a patient in the PACU.
Don't stop, family.
Okay, she wants to know where her family is. She must be anxious.
Dolor.
Oh, that means pain? Yes, I can get her pain medicine, sure.
Frio.
Oh, she's cold? Yeah, the PACU is really cold. I'll get her a warm blanket. Thank you so much for your help. Here's a warm blanket to make you feel better. Here's some pain medicine. I'm going to push it very slow, over 2 minutes at least. And I know you're anxious. I'm going to go get your sister from the waiting room to come be with you. Lastly, I think these bright lights are probably too high, so let's turn those down. All right, Miss Martinez, I'll be back to check on you in a little while.
Gracias.
This is an example how you can comfort your patient by changing their environment, by helping them with their physical pain, by comforting them through psycho-spiritual ways, such as decreasing their anxiety by getting family members, and also being socially relevant by using a translator phone if you need to. So thank you, Miss Martinez, for your participation, and now we're going to go over to the pediatric ICU, where a family's about to go down for surgery.
Hello, I'm Katie, and I'm here in our pediatric procedural room taking care of baby Joey. He's actually going for surgery later, but first he needs to get some labs drawn. So we took him to the procedural room, which helps improve the environment, just so he doesn't associate pain with his room. We also allowed his mother to hold him throughout the procedure, and before and after, obviously, and that kind of helps both of them in the psycho-spiritual aspect of the comfort theory. It kind of eases both of their pain and anxiety, and allows them to just be a little bit more relaxed. The mother was very, very concerned and anxious about the procedure later, so we've called the chaplain to kind of come and comfort her and Joey. And then also for baby Joey during the procedure, it could be painful, and the only way to know that is in order to use a pain and comfort questionnaire appropriate for the child's specific age. In this case, we would use the FLAC scale, which shows the face, legs, arms, crying, and consolability to see if he needs anything. And we would give him, if he needs pain medicine or just reassurance or environmental changes, then we would apply them as appropriate.
Thank you so much for letting me hold Joey before he goes for surgery. It means a lot, and thank you for calling the chaplain.
You're so welcome.
Well, guys, that concludes our episode this week for Getting to Know Your Theorist. As a recap today, we've got to meet the fabulous Dr. Catherine Kolcaba. Thank you so much for your time.
It's been a pleasure.
Thank you. And we've also gotten to see her explanation of the conceptual framework, as well as applying the comfort theory to two very specific patient examples. So we'll see you next week when we're back with another surprise theorist. Bye.